So, good morning to everyone. This is Nithish. I'm here to present on behalf of our Medicine 2. So, my topic is Unveiling the Hidden Culprit. And I'm going to talk about a spotter. Can anyone guess what the sign is? Yeah, it's a Pemberton sign. So, moving on with the history, a 24-year-old student from Delhi presented with the loss of weight of 4 kgs in 4 years. Loss of appetite was present, chest pain for 1 month, and shortness of breath for 1 month. Past history wise, no known comorbidities. Personal history, apparently normal bowel and bladder habits. Consumes a mixed diet. Is alcoholic and smoker. Stopped 6 months back. And examination findings: vital pulse rate is 82, blood pressure is 110/80, and respiratory rate is 21. And doing general examination, there is no pallor, icter, cyanosis, and clubbing, but there is a bilateral axillary lymph node palpable, which is 1 into 1.5 centimeter. Also, left inguinal node is also palpable. No goiter present. On doing a systemic examination, CVS shows S1 S2 here, no murmur. But on doing a respiratory system examination, it shows a D spine sign presence, which is a bronchial breath sounds uh, here below T4 posteriorly, and the right infrascapular and axillary breath sounds was absent with the stony dullness. Abdominal examination shows soft, non-tender, no palpable liver or spleen. Drop hospital. CNS is no focal neurological deficit. Clinical syndrome: the patient is having a chest pain with the loss of weight and appetite with the lymphadenopathy, mild splenomegaly, plus a right mild prolifation with D is spine sign present with the Pemberton sign positive, suggestive of a SVC syndrome. And the differential we consider could be a mediastinal mass due to a lymphoma, could be an Hodgkin or a non-Hodgkin, and second could be the sarcoidosis, and third will be the mediastinal teratoma. Fourth will be the very less unlikely disseminated tuberculosis. The sign showing is the Pemberton signs, and the syndrome we consider as a and the syndrome shows as a superior vena cava syndrome. A little bit about Pemberton sign. It was Hugg's Pierre Pemberton was the one who described the Pemberton sign in 1946. It is a clinically important in retrosternal goiter, mediastinal tumor, and superior vena cava syndrome. It is helping in early diagnosis and the surgical planning. Then how to demonstrate? Ask the patient to sit or stand comfortably. Patient has to rise above both arms above their head, bringing the elbow close to the ears, and this position has to be held for 60 seconds. And the positive Pemberton sign shows a facial congestion and erythema, jugular vein distension, dyspnea or the stridor, and cyanosis will be seen only in a severe cases. And the positive signs mostly seen in thyroid related causes, like in retrosternal is the most common cause, and the thyroid malignancy with the mediastinal extension. And the mediastinal mass will be the thymoma, lymphoma, and the teratoma. And the proposed mechanism for Pemberton sign is the cock effect. When the arms are elevated, the thoracic inlet becomes narrower due to the mechanical compression. If it is a large goiter or a mass is already present, means this will further exacerbate the compression of the vital structures like superior vena cava that causes the venous congestion. If it compresses the trachea, causes a respiratory distress. If it is compresses a brachiocephalic vein, it shows a jugular venous distension as is seen in the patient. And once the arms are lowered, the pressure on the thoracic inlet is relieved and the symptoms is resolved. And these are the features when we do a Pemberton sign. And superior vena cava syndrome causes lung cancer as the most common malignant cause, and mediastinal fibrosis, aortic aneurysm, and the thrombosis of the SVC. On our patient, we did routine investigations. Also, we did a tumor lysis workup shows normal. We also did a BBS shows negative. Bone marrow shows normal. Expert is negative, and the chest X-ray shows right side pleural effusion in the lower lobe. And we also did a PET CT. It shows a multiple bilateral supraclavicular nodes with a large lymph node mass involving the pre and the paratracheal regions. Few small lung, left lung, lower lobe, soft tissues, density lesions are seen, and multiple bilateral paraaortic and the periportal lymph nodes were seen. And more likely, we consider lymphoma as a possible cause for the patient. And our patient, we planned for biopsy on Monday. And the learning points is importance of eliciting a clinical signs in making a yearly diagnosis. Though pampered sign is easy bedside test, it will elicit, it will easily recognize the respiratory causes as we can manage it yearly.